Peace. Hi, it's Heart Love. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up after completing chapter 10 in the last reading. Episode number 30. This is episode 31. We pick up at page 193. Peace. I'm your moderator and narrator, Uriel Riley. Welcome, YouTube. Peace. All right, let's do it. So we start off a new chapter today. Peace. Yes. Peace to all my family, friends, all my mods. Happy Sunday. Chapter 11. Sustained Maximal Inspiratory, S.M.I. Therapy, Incentive Spirometry. All right. Since the introduction of IPPB therapy in the 1950s as a therapeutic regimen for bronchial hygiene, few have questioned its effectiveness in the very ill or debilitated patient with acutely retained secretions or acute absorption atelectasis. However, as this technique became widely applied for routine prophylactic therapy, its dubious effectiveness in these patients, along with the considerable cost, led to seeking more cost beneficial methods for prophylactic bronchial hygiene. Several techniques were attempted in the 1960s with little success. Inspiratory maneuvers such as blow bottles, tracheal suctioning, and spontaneous coughing proved disappointing, probably because they did not improve lung inflation or improve the effectiveness of the cough. Carbon dioxide inhalation via rebreathing techniques to induce hyperventilation enjoyed popularity for a period of time. This technique was not effective because patients with pain on inspiration tended to breathe faster rather than more deeply. The 1970s produced the incentive spirometer, a technique that appears effective and appropriate for prophylactic bronchial hygiene. Defining S.M.I. Spontaneous inspiration is a result of the muscles of inspiration producing an increased transpulmonary pressure gradient. See chapters 3 and 21. Inspiratory flow will continue as long as a trans-airway pressure gradient exists. Thus, if a patient is encouraged to sustain the inspiratory effort as long as possible, a maximum inspiration will result. Peace, highest heart love. Welcome you to the live book reading of Clinical Application of Respiratory Care. We are starting out with the new chapter, chapter 11. Welcome to the corner of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. So thank you for reading with us. It's a very high level book. So yes, just hang in there. All of the vocabulary I put into the description. So you'll be able to derive more information when I complete the reading. Thank you so much for being here. In normal man, a sustained maximal inspiration (S.M.I) can produce transpulmonary pressure gradients in excess of 40 centimeters H2O for 5 to 15 seconds. In the absence of significantly increased airway resistance or decreased lung compliance, this maneuver can result in tidal volumes in excess of 40 milliliters over kilograms. Page 194. Rationale for S.M.I. prophylaxis. Approximately 6 to 9 times per hour, the normal adult's tidal volume of 6 to 7 milliliters over kilograms are interpersed. Yes. Interpreted with deep inflations, size that approach total lung capacity, alteration of a normal breathing pattern to one of shallow tidal volumes without size results in gradual alveolar collapse within 1 hour. Therefore, it seems logical to assume that the development of atelectasis, retained secretions, and pneumo, pneumonis, pneumonitis in the acutely ill, obtunded, postoperative, or bedridden patient may be due to a similar process. Studies in both dogs and patients indicate that inflated alveoli remain open for at least 1 hour after the onset of hypoventilation. Thus, hourly sustained maximal inspiratory maneuvers should provide an ideal prophylactic measure for atelectasis and retained secretions. Peace, hi, heart love. Thank you so much. Yes, respiratory. Oh, respiratory therapists in the chat. Awesome. Peace, Stanford. Hi, it's heart love. Thank you for reading with us. Thank you for the likes and subs. We got a Resptech in the chat. Woo! We love all the healers, all the nurses and doctors. Oh my goodness, this is such an honor. Thank you so much for reading with us. Thank you for the likes and subs. This peaceful part of YouTube where we read books and learn from masters. Right now, we are reading anatomy and respiratory care in this fabulous book, Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So we're in chapter 11 in the middle of page 194. The incentive spirometer. Peace. Thank you so much. We're pushing to 1,000 subs reading books here. The incentive spirometer. The incentive spirometer is a device that allows the patient to perform S.M.I. without added resistance while presenting a visual quantification of his effort. This provides an incentive or goal and hopefully encourages the patient to repeat the maximal effort frequently. The original type of incentive spirometer has a variable preset inspiratory volume with a light that turns on when that volume is reached. The light stays on as long as the inspiratory flow rate is maintained. The patient is encouraged to keep the light on as long as possible while increasing the preset inspiratory volume by increments. More recent devices utilize various mechanisms whereby flow through a tube lifts a colored ball up a column. The sustained inspiratory flow is rewarded by the balls reaching its goal and being sustained. Each device has a simple method of increasing the flow required to reach the goal. The primary advantage of the newer generation of incentive spirometers is economic. As with IPPB and aerosol therapy, the incentive spirometer itself does not assure effective therapy. Simply leaving the device in the patient's room without proper instruction, supervision, and follow up has little benefit. The adequacy of SMI therapy is dependent upon the patient's physiologic and emotional limitations. The main advantages of the incentive spirometer over IPPB as a prophylactic regimen are that 1. It appears to be a more effective prophylactic technique. 2. The patient potentially receives more frequent therapy. And 3. Personal personnel time and therefore cost is minimized. Another advantage of SMI therapy is that performance appears to dramatically decrease when acute pulmonary disease occurs. Our experience with quadriplegic patients clearly demonstrates that early acute pulmonary disease, pneumonia, atelectasis, is reflected in sudden inability to perform previous levels of SMI therapy. This most likely reflects an acute decrease in ventilation reserve. Very key, right, Stanford? Higa. Oh my goodness. That's right. See, thank you so much. Yes. And that's what we want to do. Give this information to the people for free, to help in their endeavors and being lights of the world. So we're all light workers here. So we know any respiratory therapists or any nurses or doctors. You're also healers too and light workers. So we want to encourage that peaceful, demeanor in our world. And thank you for helping us cultivate that. We just honor to all of you. Thank you so much for doing the good work. Clinical goals for SMI therapy. When appropriately applied and supervised, SMI therapy will 1. Optimize lung inflation, 2. Optimize the cough mechanism, and 3. Allow early detection of acute pulmonary disease. Optimize lung inflation. As often as each hour, the lungs are maximally inflated in a manner that assures optimal distribution of ventilation. This is believed to help prevent atelectasis and accumulation of bronchial secretions. Very key. Optimize cough mechanism. Optimizing the inspiratory capacity should provide an optimal forced vital capacity for coughing. Early detection of acute pulmonary disease. Frequent SMI efforts establish baselines for the patient, therapist, nurse, and physician. Sudden decreases in the ability to perform the maneuver demands careful pulmonary evaluation for acute disease. In our experience, this occurs 12 to 24 hours prior to obvious clinical evidence of pneumonia and atelectasis, fever, tachycardia, and tachypnea. Criteria for SMI therapy. Guidelines for appropriate administration of incentive spirometry SMI therapy for the acutely ill patient are as follows. 1. The patient must be cooperative and motivated. 2. The lungs should be without acute atelectasis, pneumonia, or obvious retained secretions. 3. And FVC greater than for forced vital capacity, right? FVC greater than 15 milliliters over kilograms, or inspiratory capacity greater than 12 milliliters per kilogram, or greater than 12 milliliters over kilograms should be obtainable. And 4, a respiratory rate of less than 25 per minute should be present. Under these circumstances, the patient is potentially capable of effective SMI. It is then the responsibility of the therapist, nurse, or physician to properly instruct and supervise the patient. Thank you so much. Highest heart love. Thank you. Thank you for being here. I know it's high vocabulary, highest level. Reading medical's clinical application of respiratory care. That's right. Only the elite like me can do something like this. So that's why thank you for coming to this peaceful part of YouTube. We read books and learn from masters. You know, I have the vocabulary to do it. And I've traveled around the world healing the people. So as light workers, that's what we do, you know. We encourage one another, we love on one another, and we help heal one another. Thank you so much. Highest heart love. Page 196 in chapter 11. Thank you for the likes and subs. We're doing it. We're still in section 3, bronchial hygiene therapy, right? Very key, very key. Administration of incentive spirometry. 1. The patient is appropriately evaluated and the procedure is carefully explained. Emphasis must be placed on why the therapy is prescribed and what it accomplishes. 2. Technical aspects of the device must be thoroughly explained. Fear and embarrassment are founded in the unknown. 3. Proper breathing technique and positioning must be taught. See Chapter 12 in conjunction with the use of the device. Yes. 4. The initial inspiratory goal should be twice the patient's measured tidal volume, but this may have to be increased or decreased to find an appropriate initial goal. If the patient is unable to manifest twice his measured or her measured tidal volume after orientation of the technique, the appropriateness of S.M.I therapy should be reevaluated. 5. The patient should be instructed to do the therapy every waking hour. 1. S.M.I maneuver each 60 seconds by the clock, repeated 4 to 5 times. This routine will A. Avoid hypocarbia, secondary to hyperventilation. B. Avoid exhausting the patient. And C. Limit the therapy to 5 minutes of each hour. Yes. Thank you so much for being here. That's why I'm giving it to you guys for free. This is a $3,500 book, and we're reading it live to you here in this peaceful part of YouTube for free. You know, that's what light workers we do. We shine light to the world. You know, we're at service. Thank you so much for reading with us. Highest heart love. And 6. The patient's goals and performance should be evaluated at least twice daily. Summary. Bottom of page 196 for the replays and all those in the playlist. Incentive spirometry appears to be the most cost-effective technique for administering prophylactic bronchial Hygiene therapy. The theoretic basis for effectiveness is valid, and it appears clinically to be at least as effective as, if not more effective than, other methods. The appropriateness and effectiveness of incentive spirometry as a therapeutic bronchial hygiene technique are not clear since its rationale is based on prophylactic studies. It is hoped that future investigations will delineate its therapeutic value. The incentive spirometer should not be considered the replacement for all IPPB, aerosol, and chest physical therapy. However, S.M.I therapy as a prophylactic technique appears to be the much needed replacement for IPPB and CPT, which are so ambiguously misused and abused. Yes. And we did it. We completed chapter 11. We did it. Chapter 11 is complete. So when we reconvene, we will go into chapter 12 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading with us. Highest heart love. I hope you had a wonderful day. Football's back, right? Oh my goodness. I hope your teams won. And if they didn't, it's just the first week. Take it one game at a time, right? That's how we track. And just like we read these books, one reading at a time. We just finished a whole chapter in one reading. So it's not like always like that, but we take it one reading at a time. We let the information settle in, and then we use it in the ways that we need to help others, shine the light on others, to give others information in that guiding light. So thank you for shaking it up in the world with me, reading books live on YouTube with super high vocabulary to keep, raising the bar. You have to keep leveling up. For people that don't read, the vocabulary is very limited. And this causes a frustration in them because they can't understand. They can't, they stay confused. And so this channel and the peace that I bring with us, that we bring with us, is to shine light for the light workers or the people that want understanding, that want harmony and embrace peace. So, highest heart love, thank you so much for reading with us. We just completed chapter 11. So, cheers to that. Love to all the family in the King's Gambit. Highest heart love. I love you, Mom and Dad. Thank you so much. Isis, my baby. Bubbles, I love you so much. I'll see you soon. I love you. You know I do. 'Cause I love myself. Thank you. I love you. I love you. I love you. Gratitude and highest heart love. Thank you so much for being here. Thank you for reading with me. Thank you for breathing with me. I love you. I love you. Anyway, I'll see you soon. Y'all have a wonderful evening. We are going to the sky blue cloud tonight, this evening. I will see you there. I'm going to be healing and looking at the Pleiades and Orion's belt. Oh, I'll see you there, all right? See you in the ethers. Peace, peace. Thank you so much. Peace, love, and light. We are the world. That's right. We're the champions.